Okay, it's right at 12. Are you ready?
I'm ready, girl. Let's do
Okay.
it.
Okay, everyone. Well, welcome back to another series or another talk in our virtual health talk series. We're so excited to have Christina here. Christina Swain is a nurse practitioner at the Heart and Vascular Center here in Boone, which Christina, I tell you this all the time, but it is one of my favorite practices. I absolutely adore all of you there.
Oh,
Um,
thank you, Maddie. You're
I
so
know.
sweet.
Well, I'm super excited for this talk, and you know that. And we both wore our heart sweaters today.
We
It's
did. We're matching hearts.
and it may not be, or it's past Valentine's, but February is Heart Health, American Heart Health Month. So this is perfect timing for this talk, and we're going to be talking about chest pain today. So we're
Yeah,
excited.
yeah,
Okay.
we sure are. I'm super excited because one of my favorite things to do is educate and empower patients. And I think talks like this really helps do that. Because
Yeah.
some people, they just have general questions or they may not really know. And maybe sometimes they think we're too busy to ask in the office. So these are great opportunities to kind of
Oh
be able
yeah.
share certain things. But yes, I'm Christina Swain. I'm one of the 3 nurse practitioners here at Heart and Vascular Center, mainly in Boone is where I am. I've been in cardiology for roughly 15 years now, but I've been working here for 5 years and I've absolutely loved it. I love the cardiologists that I work with, love Maddie, love the nurses in the hospital, and I actually think we have a really good program here, especially for being kind of a smaller hospital and in kind of a more rural area as we're classified as.
Yeah.
Um, so yeah, today we're going to talk about chest pain, kind of chest pain in ways that maybe if you're having symptoms and you're not really sure if you should be concerned or not, talking about certain characteristics that we should worry about, when maybe you should seek attention a little bit quicker, and of course, when you should always talk to your provider about it, whether it's me, your primary care doctor, or your cardiologist. So obviously there are many things that can cause chest pain. Chest pain is just a general term really that we use that includes all of your chest. So it could include, even GI stuff. It could include lung problems that are causing inflammation, musculoskeletal issues, uh, you know, and the obvious things that people think of is problems with your heart. And problems with your heart doesn't even always necessarily mean that you're having blockages in your heart arteries, which we call coronary ischemia, causing those chest pain symptoms. It could be something else going on with your heart that could be causing your chest pain. So we're going to talk about some of those differences, and then probably one of the things that I'm most excited about is talking to everybody about how we evaluate it, both
Mhm.
from an outpatient standpoint and from an inpatient standpoint. Because just because you have chest pain, doesn't mean that we always have to do drastic measures or always need to ignore it either. So there's kind of things that we can do uh, to look into those symptoms that you're having.
Awesome. And I also forgot to mention this, just a housekeeping item. For those of you that are attending, you are permanently muted and your cameras are permanently turned off, so Christine and I cannot see you. So if you have questions, please put those in the chat and then we will answer them at the end of the health talk. And I also wanted to throw in there, if there's some kind of crazy emergency and there is a STEMI, Christina may have to leave
Mhm.
us
Yes, I
early.
am at work today, working in the hospital. So unfortunately, if there's an emergency, I will have to cut this a little bit short. But
Yeah.
here at the Heart and Vascular Center, we are always here for you for anything you need. So you can talk to us or your primary doctor if you have any questions, obviously.
Oh.
But yeah, we'll jump right in. So we are first going to talk about some less concerning chest pain characteristics. And I call this less concerning because these are more of the characteristics that we think of with what we call atypical chest pain, or chest pain that isn't necessarily anginal in nature. Anginal meaning it's probably not caused by a blockage in a heart artery, leading to lack of blood flow through that artery and therefore starving your heart muscle of oxygen and causing those symptoms of chest pain. This is probably caused from something else. I put a little bit in the slide there. I like that little picture, common causes of chest wall pain, because sometimes people have symptoms of chest pain that definitely are not related to anginal symptoms going on. Some of the descriptors that people may use that, we're not really triggered by thinking that it's anginal. If they say that it's sharp, if it's stabbing pain, maybe it's sore, maybe it's a throbbing pain, and especially if it's a very quick pain. So the duration lasting just a few seconds, maybe less than 30 seconds, that's usually something more like nerve, inflammation, musculoskeletal, positional. If you move in a certain way and the pain gets worse, those are things that we aren't too concerned about. Also pain, and I think this is a big one because sometimes patients come to our office and they say, oh, I've been having this pain, it's been constant, and it's been constant for like 5 days. Or sometimes they'll even tell me it's been constant for months. And usually when pain is constant, that's actually a good thing. If it's been going on for a long, long period of time, if it was something bad, then something bad probably would have already happened. So having pain that is lasting very, very long periods of time or very short periods of time are less alarming or less concerning.
Yeah.
Other things that we think about, what's making the pain worse and what's making the pain better. If pain is getting worse, like I said earlier, if you move a certain way and it gets worse, that's probably musculoskeletal, inflammatory. If the pain is worse when you take a deep breath in and out, again, that's probably inflammatory pain, not necessarily the concerning anginal pain, caused by a blockage in a heart artery. One of the big ones that is also heart related and is still very important for us to know about and evaluate is sometimes people get pain when they take deep breaths in and out, really sharp pains when they take deep breaths in and out, and really it's only relieved, honestly, usually when they're sitting straight up in a straight up position. If you start to lean forward, you get the pain again. If you start to lean back, you may get the pain again. These are very classic symptoms for something called pericarditis or inflammation of around the heart. Your heart actually sits in a sac called the pericardium, and if that sac gets inflamed and your heart starts rubbing up against that, it can cause those symptoms of chest pain. Again, something that's very important, but these are things that are not life-threatening or an emergency.
Right. Now, if someone were to have some of these symptoms, or even if it's a sharp pain for less than 30 seconds, do you still recommend for them to be like rather be safe than sorry and contact you? Or
Yeah, absolutely. So if you're a patient at our office, or if you have a cardiologist at another office, Dr. Fox or one of them, it's always a good idea to talk to your cardiologist or your providers about these symptoms that you're having. Because like I said in the beginning, it's probably not worrisome, but sometimes we can tweeze out things, get other little symptoms that may, help us decide if this is more worrisome or not.
Right.
And some of the things that do help with that next line there, no other associated symptoms with pain. So if you're having symptoms of chest pain, but you're not having any diaphoresis, you're not having any shortness of breath, you're not having any fatigue, dizziness or anything like that, it's usually safe for us to say this probably isn't something where we need to think about, getting something done urgently or right away. We can probably evaluate this in more of a simple way. So talking to your provider about it is obviously very important because we use a lot of different, questions and kind of feedback from you to decide what's best for you.
Yeah.
So yeah.
Okay, now it's more concerning.
This leads us to the things we should definitely be more concerned about and always talk to a provider about. So when we think of the classic, pictures of people running on TV and they stop suddenly and clutch their chest and, oh, they're having these, chest pressures, elephant sitting on my chest. That's what everybody always thinks of when they think of anginal pain or pain from that blockage in a heart artery. But some people do describe it a little bit differently. Pain that feels like a heaviness or a weight on the chest, a tightness, or like this pulling across the chest, a pressure like someone is holding down on your chest and not letting up. And this one's a little bit trickier, the fullness and burning. So this is kind of more more so seen in women. Again, if you have a fullness or burning, we're very concerned about that. But it can also be something that's GI related, and we just talk to you a little more, ask you some more questions to kind of try and discern that. Now, duration of chest pains that are a little more concerning. So if your chest pain is lasting 5 minutes, 30 minutes, and it's having those characteristics of the heaviness or tightness, that's pretty concerning. Chest pain that's serious, it's usually onset when you're doing something, when you're exercising, when you're very stressed out. And while you're doing those things, for 5 minutes or 30 minutes, you're having those symptoms. The other thing that is very important is maybe you have this progressively worsening chest pain. So maybe a month ago, I had an episode of chest pain that was a heaviness. Maybe it lasted about 5 minutes, but it went away on its own and I didn't tell anybody about it and I kind of just ignored it. Then a week after that, maybe it happened again. It was a little bit stronger, lasted a little bit longer, but again, it went away on its own, so I kind of ignored it again. And then it happens again. And, when we have these kind of progressively worsening or stuttering, that's how I describe it, as stuttering chest pain symptoms, kind of coming and going but worsening each time, that's actually very concerning. So we definitely want to know about those things. If your chest pain is associated with symptoms of shortness of breath, nausea, dizziness, sweating, sometimes people will describe radiation of the pain up to their jaw, down their left arm, but it doesn't have to be the left. It can also be the right and through their shoulder blades to their back also. Those are characteristics where we become more concerned, and we definitely want to check you out, and you should definitely talk to your provider about it.
Yeah.
So if not, call 911 and go to the emergency department if it's very, very bad.
That was a question. I was just talking to my coworker before this health talk, and I said, what do you do if you're having these symptoms, you're having these bad symptoms, and you call 911? What do you do while you wait for 911? I was telling my coworker, I said, she knows me well, and she knows I'm a I would panic, like I would get more panicked.
Yeah,
So
hopefully you're not by yourself. It would be more beneficial if you have somebody that's with you that can help you. But if you are by yourself and having very concerning symptoms that aren't letting up, definitely calling 911. If you have access to baby aspirin, we recommend that you chew 4 baby aspirin while you're waiting, and just kind of, I know this sounds very hard, but just kind of sit and relax as much as possible. We don't want you kind of like up and running around and maybe aggravating things a little bit worse, just waiting for the EMS people to get there. And, during that time, if you want to call family and let them know what's going on, if you have access to that, then that would be ideal also. Now, if somebody is there with you, having them kind of take care and look for the aspirin and call 911 while you just kind of try and sit and chill while you wait is probably the best thing. So,
okay.
Yeah.
It was a question that had popped into my mind.
Oh, I'm sure a lot of people have that question. Very good question. And obviously, just like we were saying before, if you are having any of these symptoms at all, having any chest pain symptoms at all, it's always best to seek guidance from a provider, whether that's your primary care provider, who are very knowledgeable about this as well, or if you have a cardiologist, talking to a cardiologist about it, or making an appointment with a cardiologist about it. Sorry, my screen went blank for a second. Or, making an appointment with us to even talk about these symptoms. Because a lot of times patients do come and see us as new patients for their symptoms of chest pain. We kind of help talk them through it and decide the best testing for them. So I wanted to start with how we evaluate concerning chest pain symptoms. So the kind of last big slide that we talked about, the heaviness, tightness, pressure, happened when you were exercising, you had shortness of breath with it. So those concerning chest pain symptoms, whether we see you in the office with those symptoms and you're telling us about them at an office visit, or if it was one of those emergent situations and maybe we meet you in the emergency department while you're having these symptoms. The way that we evaluate that is with a procedure called a left heart catheterization, or a left heart cath is how we call it. Now, a lot of patients do get this a little bit confused sometimes because they think, a left heart cath, are you only looking at my left side of the heart? That is not true. This is just how we access to look at all your heart arteries. So when you have a left heart cath, what we do is we kind of put you in a sleepy state. You're not completely knocked out. You're still able to breathe on your own, but we take these long, skinny tubes, kind of like a long, long straw. And most of the time we go through the artery of your wrist here while you're sleeping. We take that straw, and that straw goes through your arteries and leads to the arteries of your heart. And from there, we give you some contrast dye, and that dye illuminates your arteries on a screen that's above your head. And that's how the cardiologist doing the procedure, called an interventional cardiologist, determines one of three things. First thing is, yes, you were having these concerning chest pain symptoms, and it sounded like it could have been due to a blockage, but we didn't find any blockage. We didn't find any major blockages, so we need to look into something further. Now, the second thing we could find is, yes, you indeed do have a big blockage, meaning greater than 70% of your vessel is blocked. And if that's the case, I would say here at Watauga, about maybe 95% of the time, we can fix that blockage during the procedure with things called a stent. Now, stents are permanently implanted to keep that vessel open. So that's very helpful for the patient that we can fix what's causing their issue at the time of the procedure. The last thing we could find, and we never know until we go in and take a look, is if people have lots of blockage. So most of their arteries in their heart are blocked, or if they have a blockage kind of in a scarier place that what we call is more risky, then if that's the case, we just talk to the patient and kind of come up with a plan from there. But these procedures, we do probably at least 2 of them a day here at Watauga Medical Center. They're done fairly often, and people do very well with them. You know, if we don't find anything, then you get to go home from the hospital the same day. If you do get a stent, you do stay one night in the hospital, though. We want to watch you just a little closer. Yeah. So I hope that kind of explains the procedure well.
Yeah, the video might be helpful here.
Yeah, I think the video will help as well. So what you're seeing now is kind of what that contrast looks like, what the physician is seeing on that screen above your head. So we give you that contrast dye, and it flows through your heart arteries just like that. Now, this is looking through your left main into your LAD and your circumflex arteries that are on the actual left side of your heart. And this example that we're showing here is completely normal. So all of that contrast is flowing beautifully through those vessels. We don't see any stops or any missing pieces, which tells us that that person has normal arteries. Now, our next video, this one is a little more, it shows the left and right side, and it's going to show a blockage. So this is looking at the left side. The left side looks pretty good. There's no significant blockage there. They're pointing out the LAD, which is the vessel that runs down the left front of your heart. Now we're looking at the artery on the right side. This is called the RCA. And you can see that black, that contrast flowing through that vessel just kind of stops right there. And that tells us that right there, there is 100% occlusion. So that contrast, that black, isn't able to flow through that vessel down through to the end of that vessel. So we know this is a problem, obviously, and this physician doing this procedure, this is not one done at our hospital, obviously, but this physician doing this procedure is now going to fix that blockage with a stent. So he's putting the balloon and stent in, he's inflating it, and you will see how placing this, now we can see that that contrast flows all the way through and all the way down to the end of that artery. So having that lack of blood flow where there was no blood flow to that muscle was crying out for help. Probably that person was having a lot of chest pain because that muscle wasn't getting the oxygen it needed. So heart caths are how we evaluate, very concerning chest pain symptoms.
Yeah, and see what's going on.
Yeah, exactly. Right then and there, we can see what's going on.
Yeah. That's really neat.
I think so too, but I'm a little biased.
We're glad you think it's neat. That makes it feel better.
The next thing we can talk about is kind of chest pain symptoms that are a little atypical or less concerning, or how we would say non-cardiac or non-anginal. And I will say, just as a caveat, sometimes people come in and talk to us in the office and we're kind of like in the middle. Like, is this maybe some anginal features, maybe some non-anginal or atypical features? And in that case, we talk to the patient. You share decision making and we come up with a plan that works best for you. But sometimes if we know that your symptoms are more atypical or we're not concerned, then we'll help guide you through different ways of doing non-invasive testing. So heart caths are obviously invasive. There's a little bit more risk involved, but these ways that we're going to talk about are non-invasive and very little risk is involved with them. So the first one we're going to talk about is stress testing. There's multiple different types of stress testing. I could do a whole talk just on stress testing, but there's two main types, without imaging and with imaging, and then we're going to touch on CCTA, or coronary cardiac CAT scanning, which we are getting here at Watauga Medical Center starting spring 2025. Woohoo! So that'll be here very soon. And then I wanted to just touch real quickly on like CT calcium scoring, just plain calcium scoring, because I feel like there may have been questions on that. We actually don't really recommend that you evaluate chest pain with this modality. But it's something just good to kind of differentiate the differences between calcium scoring and a CCTA. So here we go. Less concerning chest pain. So kind of the simplest of the stress tests is something called a treadmill stress test, or we also call it an exercise treadmill test, a TST or an ETT. Now, doing this type of stress test, we are not using any imaging, no ultrasound imaging, no nuclear imaging. We're basing everything off of just those squiggly lines, the EKG that you're hooked up to. So in order to have an accurate test, you have to have a baseline normal EKG. And your doctor, your provider, whether it's your primary doctor or us, we obviously will help determine that. If your EKG is normal and your chest pains are really not concerning and you can walk well on a treadmill, at least 6 minutes, then this may be the test that's recommended for you. Even though there's no imaging involved, we get a lot of information from looking at an EKG while you're on a treadmill. How the electrical pattern moves through your heart actually changes if you have issues with blood flow or blockages in your heart arteries, and we can easily identify that by looking at those squiggly lines, those waveforms on your EKG. It also gives us good information on symptoms that you're having. So if you're walking on the treadmill doing great, you've walked maybe for 9 minutes and you've not had any symptoms, this is very reassuring to us that probably everything will be okay. So that's the first very simple stress test that we have. The second types of stress testing, or how I kind of categorize them, is then we have stress testing with imaging. So we can do imaging here at Watauga with either nuclear imaging, that's that first kind of colorful, glowy looking picture, and then we have imaging with stress echoes as well, which are ultrasounds of the heart. And these are both kind of done in a similar fashion, but just using different imaging, obviously. So we get rest pictures of the heart. So you just laying there, us taking pictures of your heart at rest. And then we do stress images of the heart. So while your heart is kind of working, we take pictures of your heart while your heart is kind of in that mode of working. Now, not everybody can walk on a treadmill. So with nuclear imaging and with stress echoes, we have the ways of looking at your heart at stress when most people would be walking on a treadmill by using medications. Probably the most common stress test we do here at Watauga Medical Center is the Lexiscan nuclear stress testing. So Lexiscan is a way that we could stress your heart out without having you walk on a treadmill. Obviously, if you can walk on a treadmill, we would prefer that because it gives us a little bit more information.
Right.
But a lot of people, as you can imagine, Maddie, they can't walk on a treadmill. So we definitely have ways to look at your heart without having you walk on a treadmill. So one of those ways.
How does that medicine work? Is it injected, or do you take it? Or?
Yeah. So when you get stress testing with imaging, whether it's the nuclear stress test or with stress echoes, it usually does involve an IV. We put an IV in you. especially for the nuclear stress testing, you need an IV.
Okay.
But when we use those medications like Lexiscan, what we do for the nuclear stress testing, we inject it very quickly. You're still hooked up to EKGs and everything like that. It's a very safe, controlled environment. But that's how we do it. The Lexiscan is very quick acting. People will feel funny when they get that medicine. It almost makes you feel like you're in the middle of a marathon, like you're going from 0 to 60 really fast. But it actually works by dilating your arteries or opening up your arteries instead of constricting your arteries like on a treadmill. So Lexiscan testing is actually quite safe as well, safer than a treadmill, believe it or not.
Okay.
So,
Crazy.
yeah, great question. Ah, my favorite. Only because we've been working on this so long here at Watauga Medical Center to get this here.
Yeah.
So there is also scanning that can be done. Scanning that can be done to look at your heart arteries. And this is something called a coronary CT scan. Some people also call it a cardiac CT scan. The easiest way to say it is a CCTA. So a CCTA, it also does involve an IV, but we give you an IV so we can inject some contrast into your vessels. And by giving you that contrast, we take pictures with a CT scan. And the nice thing is we get very beautiful and accurate pictures of your heart arteries. Some people kind of describe a CCTA as a heart cath without being invasive. So we're able to get great pictures of your heart arteries, obviously just like we do on a heart cath. But it doesn't involve putting you to sleep, no big needles, no medicines or anything like that except for the contrast. The things with the CCTA is obviously not every patient would be a great candidate for it. You kind of have to meet a certain set of parameters. You have to have a regular heart rate. You have to have a slower heart rate because we actually give you medications that really slow your heart rate down during the procedure, something called low pressor. We give it to you through your IV as well, but that helps slow your heart rate down so we can take a lot better accurate pictures of your vessels. So if your heart rate's going fast, things just get blurry and it doesn't work very well.
Yeah.
Kind of one of the things, I don't know if there's any providers like primary care doctors watching, but an easy way to kind of, for me to try and explain it on, how do you know what to order? So your patient is having these kind of atypical chest pain symptoms. You know you don't want to set them up for a heart cath quite yet. How do you know whether to do a stress test or a CCTA? They give you both very good information, but both very different information. So a stress test gives us more qualitative data. How does the patient do on the treadmill if they're on the treadmill? And then with the pictures that we're looking at, we're actually looking for ischemia. We don't visualize the heart arteries on a stress test. We're looking to see if there's any part of the muscle of the heart that's having an issue getting good blood, and therefore the pictures will look different. Now with the CCTA, it's different, obviously. We are fully able to visualize the vessels, but we're not able to visualize how impactful a blockage may be. So we may see that you have a blockage on your CCTA, but we may not be able to tell for sure whether that blockage is significant to the patient or not. So just two different things to think about. Now, usually in cases with both CCTAs and stress testing, if they're abnormal, both of them usually lead the same direction to a left heart cath. So,
Okay.
yeah. Okay, and then finally, calcium scoring. I just wanted to touch on this because I know some people get confused between calcium scoring and CCTAs. So calcium scoring isn't something that we recommend people get if they're having chest pain symptoms. It doesn't mean it's a completely bad idea, but calcium scoring is used more so to determine somebody's risk. So calcium scores are good for people who are maybe in their 40s to 60s. Kind of after the age of 60, you pretty much know someone's going to have a little bit of calcium, so you know it will be abnormal, so it's kind of not worth it at that point. But if you're trying to determine somebody's risk factors, how aggressive do you need to be in trying to guide this person on managing their potential coronary artery disease or blockages in their heart arteries? Calcium scoring can help you with that. If your calcium score is 0, then you know you don't have any hard plaques or calcified plaques in your heart arteries. But if your calcium score is, elevated, in the guidelines it literally says anything greater than 0, then you have to work with that patient to, maybe put them on certain medications, a baby aspirin, cholesterol medicines, things like that to help prevent things from happening in the future. So calcium scoring is more used so as like a preventative measure, trying to, like I said, determine someone's risk, whereas CCTAs are actual ways where we evaluate chest pain or anginal symptoms.
Okay. So do you do
Yeah.
calcium scoring all the time? Is that something that's...
So I'll be honest with you, like obviously we do it here, but a lot of times primary care doctors order calcium scores. And then if a calcium score is abnormal, then they will refer the patient to us.
Got it.
So
Okay.
yeah, so it kind of helps them determine like, oh, this patient is going to need to follow with cardiology. They obviously already have something in there. So it's a way for them to get the patient's foot in our door. So
Got it. Got it.
yeah.
Okay, well, I'm going to stop sharing my screen so I can look at the chat. And we
Okay,
can see,
sounds good.
if anyone has any questions, this is the time to ask. Okay, you've got a few questions.
Oh,
Okay, are you ready?
yes.
Oh, wait. Oh, actually, hold on. Actually, this one was about that they could not hear. It looks like one person could not hear.
Oh.
I hope that they were able to
Oh, I'm
hear. I
sorry.
didn't see this before. And someone said while waiting for 911 to come, you mentioned to sit. Would lying down help and putting feet higher than the heart help?
I don't think it's going to hurt you. I think that if you can easily get into that position, that it's perfectly fine. I think just making sure that, you're not standing or moving around, because if something more serious did happen, like passing out or something like that, then you know that you're already low enough to the ground. When people have low blood pressures, that's usually when we recommend the lying down position with putting your feet up. Sometimes when people are having issues, they actually have high blood pressure. Sometimes they have low blood pressures. It's always different kind of depending on how bad the lesion is and where the lesion, meaning the blockage, where the blockage is. I don't think that it would hurt you though.
Okay. This person asked, which is actually one of our providers here, asked, what if, I guess they're assuming if one of their patients had a calcium score of 0, but LDL of 170, what would you recommend?
Oh, that is interesting. I wonder how old that person is. So technically, if you have a calcium score of 0, then they don't necessarily need to be on a statin yet.
Yeah.
If their calcium score, sometimes calcium scores can even be like a 0.2 or 0.4. That's why they just say anything greater than 0. That's where they recommend statins. You can also use the like ASCVD to kind of guide your risk and see if statin therapy would really lower the risk score. For those in the general audience, that's like a risk score calculator to determine if somebody should have like tighter cholesterol management. So you can use that as well. But if you have a calcium score of 0, then it's not necessary that they be on a statin.
Yeah. Well, that provider that asked that question, she now has your contacts, so she can reach out to you and ask you questions if she has any more questions.
Perfect.
We had someone that commented and said, I had a STEMI in 2023 with no chest pain at all, just a tightness in my upper shoulders and profuse sweating. So he was sharing his symptoms of...
Yeah, and we definitely see that. I know we were talking about just chest pain today, but there are obviously other symptoms out there that could indicate that there's a problem going on. Tightness in the shoulders and back. Some people just have like exertional shortness of breath or exertional fatigue. And these are alarms as well. These are things that you should let your doctor know. Kind of the hard thing about those symptoms is obviously a lot of things can cause exertional shortness of breath and exertional fatigue, but we always want to make sure that it's not the heart, because the heart can play a part in that. But there's definitely some other signs that people can have besides chest pain that's definitely related to the heart. Good comment.
Crazy, yeah. Okay,
Yeah.
this person said, how much does menopause contribute to a woman's risk factors?
Oh, that's a good question. Um, so menopause itself, and I am not the expert in this, I will say. Menopause itself, I don't know if that going through menopause itself increases risk factors. I know that being put on certain hormone therapies through menopause can increase risk factors.
Mhm.
So a lot of times we'll recommend that certain females get taken off estrogen therapies and stuff like that if we think that they're high risk. Um, but but I'm not sure about the menopause thing. I can get back to that person on that if they would like.
Cool. While we're waiting for if anyone else wants to ask questions, they can put it in the chat. But I had a few questions for you myself.
Oh yeah.
I jotted some down, and I was just thinking about I'm in my 20s right now, and I know we should always be thinking about our heart health, but sometimes you just think like, well, I'm in my 20s. I'm invincible, you know? So, what are signs of some heart issues that someone in their 20s or even their 30s shouldn't ignore?
Mhm.
Um, I don't know.
That's a great question.
Yes.
So just because obviously I know you're very healthy, Maddie, and just because a person in their 20s or 30s would classify themselves as healthy, meaning they themselves don't have any risk factors. They're a non-smoker, they don't have high blood pressure, you also have to think about the genetic component of coronary artery disease. If you have an early family history of heart attacks in your family or heart failure, or even some people have sudden cardiac death in their family. These are things that you should definitely talk to your physician about if you have a family history of that. But even if you're in your 20s and 30s and you're not really sure about your risk factors, but you're having chest pain, you should still mention that to your provider because it's definitely much more rare, obviously, for people to have blockages in their heart arteries at that age, but it's not zero. I've definitely seen it. Many times I've actually seen a high school student come in with a STEMI. So there's always that risk. Yeah, there's always that risk that it could be something serious that we would want to look into. And like I said, there's other things with the heart that can cause chest pain, like pericarditis. We saw that a lot around the COVID and the COVID vaccines, a lot right now, during times of viral illnesses. Viral illnesses significantly contribute to the risk of developing pericarditis, which is that inflammation of the sac around your heart that your heart can rub against and cause some chest pain. That's pretty common actually in young people. Same with something called myocarditis. Now this is where that inflammation migrates into the muscle of the heart itself and is much more serious. So there are definitely things that, it doesn't necessarily have to be a blockage in a heart artery, but it's something very important that we need to look into that could be heart related.
Okay. Wow.
Does that help answer your question?
Yes, it does. It does. And another question I wanted to ask you too, I'm sure other people on this call may also have jobs where they're sedentary or they're sitting at a desk all day. Um,
Mm-hmm.
how does that impact your heart health? And I even think about with myself, being in
Yeah.
marketing, I'm at my desk a lot, but then I go home and I'll try to exercise or work out when I go home, but still
Yeah.
sitting at my desk for almost 8 hours a day, how does that impact heart health? And I'm sure a lot of people
Yeah.
all can relate to that.
Yeah, this is tough because I sit at a desk a lot too. I mean, I'm up and down between patients, but obviously the more consistently active you can be, the better. The thing that can, and if you're exercising still, a few times a week, at least 30 minutes of kind of cardiopulmonary exercise, getting your heart rate up there, it should still really balance out for you. But what can happen is something called deconditioning. And if people kind of just become really lazy and they get deconditioned, then your resting heart rate can go up. The requirements on your heart as far as the efficiency goes down. So when the efficiency of your heart goes down, your heart rate has to go up to kind of compensate for that. Because with every pump that your heart does, which is every heartbeat, that's acting as the pump to circulate the blood. And the amount of blood that is ejected from the heart is called your cardiac output. and your body tries to maintain a certain level of cardiac output. Now, if you are deconditioned, then the requirements on your heart actually go up as far as the heart rate has to go up in order to maintain the same cardiac output. So somebody who is primarily sedentary is at more risk for that sort of deconditioning type of thing.
Yeah.
But trying to get up and stay active throughout the day is also important.
I know my boss and I, we like to, during our lunch time or our lunch break, we like to try to go and walk, since we're so close to the Greenway here, try to go
Yeah, that's
to a lap around the
great.
Greenway, and try
Yeah,
to move a
yeah.
little bit. We also, most people here in the marketing department, we do have our standing desks, and I should have propped mine up and had my standing desk up. Speaking of
Set a
walking
good
and
example.
yeah, I should have done that. Speaking of exercising, someone put a question here. It says, are certain types of exercise best for heart health other than running or walking or other cardio? Do you have any other recommendations?
So anything kind of getting your heart rate up is good. Now, everybody can calculate their target heart rate. It's 220 minus whatever age you are. So that's your target heart rate. So that's kind of the zone we would want you to get. And that's actually the target that we get when we do stress testing. We use your target heart rate. So we would want that person to try and reach within that zone. Doesn't have to be exactly that zone, but within like 80, 85% of that zone. So it's really looking at your heart rate and sustaining at that heart rate for, a good while, 20 minutes or so. That gives you a very good cardiopulmonary exercise. So it doesn't necessarily have to be running or biking or something like that, just anything that can get your heart rate up. Some people like to do the stairs. That really gets my heart rate up, and I get very short of breath when I do the stairs. So I hope that's helpful. Even using like light weights, moving around with weights, even just kind of stick movements, but getting your heart rate up, that's really what we look at is looking at your heart rate.
Yeah. That made me just think about, with a lot of smartwatches, obviously you can monitor
Yeah,
your heart rate, but I know there's some of the newer models of smartwatches now do the EKG and stuff.
they do.
Do
And
patients
they're
come in
actually
and
quite accurate.
really, I was going to ask you that. I didn't know if
Yeah,
patients come in
yeah.
and bring that up to
Some
you.
of them more so than others. The ones that show the actual EKG tracings and not just the heart rate,
Mhm.
those ones are definitely more accurate. We still don't typically diagnose somebody based off of that. We still do our own heart monitors and things. But there's actually certain trials going on right now, not here, but I know there's some going on at Baptist about using those watches to help guide even treatment. So people who have AFib, totally different topic, but they kind of use those watches to see how often they're having AFib and kind of doing treatment based off of just what the watch is telling them. So
Interesting.
so they do work. They do work. The ones that just show the heart rate, I've noted, are not nearly as accurate. Like I think just like the basic Fitbits maybe and stuff like that. I've definitely had patients come into the office and tell me their heart rates were in the 30s on their Fitbit. But we do an actual monitor and it's the opposite. Their heart rate's going too fast. So I know that those are not as accurate. Yeah.
Oh, okay. Well, that's so
Yeah.
interesting. That's just crazy. Okay, Christina, we only have 2 minutes left, and it doesn't look like we have anyone adding any other questions. But thank you
Oh,
so much.
good.
This was
Oh, thank
great.
you.
I
I
love
hope
when we
that
talk about
everybody
heart health.
enjoyed. Yeah.
Yes. I'm sure that they did. I really enjoyed it. People are
Oh,
chiming in
good.
and saying thank you. And as we close out, I'm going to share my screen one more time. And Christina, this has all of your information on here. So if anyone wants to follow up with Christina, um, the phone number for Heart and Vascular is on the screen here, and this QR code will take you to our website, our Heart and Vascular website.
Yay.
But we're so glad
Yes.
that everyone attended. And Christina, thank you so much. I'll hang out
Oh,
here for a little bit,
good.
but people can hop off. Yeah. Thank you. Thank you,
Oh,
everybody.
thank you everybody so much for joining in. I really appreciate it. Everybody have a great day. And We didn't miss me, yay.
I know, it's like, go on your lunch. Well, everyone just spent their lunch doing this, but you've got maybe 15 minutes left of your
I know
lunch
I've
break.
got 15 minutes for my lunch, so that's
Yeah.
perfect. Thank you, Maddie, so much. I had a good time. I appreciate
Thank
it.
you. Bye. I'll talk to you
Bye.
soon.
All right.
Bye.